So I'm going to discuss some important concept regarding the shock management. As everybody knows, shock is mainly a life-threatening issue. So there are a couple of definitions. So I don't want to elaborate on the definition of shock. So there are main four broad categories of shock, especially hypovolemic, obstructive, cardiogenic, and distributive shock. The main pathology behind this is the oxygen delivery, as everyone knows. So I'll move to a case discussion. So I have a 60-year-old man who is known to have a hypertension. So he come into the emergency department at around 6 a.m. with severe abdominal pain, vomiting, but this was started previous day night. So he's tachycardic, low blood pressure, and his respiratory rate is marginally high, and he's maintaining low saturation in room air. So his temperature is normal when he's conscious. So on arrival, patient is pale and he is having obvious abdominal distension and tenderness and GERD. So if this clinical picture comes to you, everybody knows that there's something problem in your aorta or the abdominal region. So we did the point of care. He is having an obvious metabolic acidosis with high base excess minus of 16 and lactate of 12. So important thing is his hemoglobin level is 13.4. So his electrolytes are normal and his sugar is normal. His ECG was sinus tachycardia. So as everybody knows, there are classification, but is currently changed, but he is obviously in the class 4 shock. So there are people in the hemorrhagic shock. It's the rapid responses, transient responses, and the minimal or no response. So if you given the patient's fluid, so you know that where your patient is going. So this is my patient's focus. So Morrison's pouch, no, there's no any blood. So, and the cardiac view also there, you can't find anything. There's no any pericardial effusion or sign suggestive of tamponade. So if you do the POCUS, you can see there's a visibly dilated aorta, which is nearly 10.6 in diameter. So pelvis, there's no any free fluid. So with the suspicion of ruptured abdominal aortic aneurysm, we inform the vascular team and the major transfusion protocol activated. Meanwhile, we started giving a 0.9 saline and the tranexamic acid and the ICU pass blip as well. So even though patient is hemodynamically unstable, they want the vascular team on the CT aorta. And few word about, before I move into the CT film, so few word about the oxygen delivery. So why we given fluid, why we given blood, and why we given additional oxygen for patient who is in shock. So ultimate, our aim is to deliver oxygen to tissue level. So if you take patients, if you go from the lower down, so you given supplemental oxygen. So given supplemental oxygen, increase oxygen delivery only around 1%. So if you increase oxygenation by, for example, 90 to 100%, so you give in an NRBM or you give in additional oxygen. So you increase oxygen delivery by 10%. So if you give in fluid bolus and you increase the cardiac output by 20%, so increase your oxygen delivery increased by 20%. So if you give blood and increase your hemoglobin 6 to 9, so your oxygen delivery is increased by 50%. That is the main aim of giving blood for patient who is having a hemorrhagic shock. So few word about the massive transfusion. Everybody knows that if patient is having a more than 40% of blood loss or 2 liters loss within 3 hours, or if patient is active bleeding more than 150 ml per minute, so patient can be categorized as a massive blood loss. So, but this is a retrospective. So everybody has to wait for 3 hours or a couple of hours to say this patient is having a massive blood loss. So how are we going to decide whether this patient need acute or a patient is having acute blood loss, massive blood loss, and the patient need massive transfusion protocol? So easy way is the ABC score. So if patient is having a penetrating mechanism, systolic blood pressure of less than 90 systolic in ED and heart rate of more than 120 with positive fast. If patient is having a equal or more than 2 points, patient require massive transfusion protocol with high sensitivity and specificity. So our patient definitely had a 2, so patient need massive transfusion, activation of massive transfusion protocol. So few word about the shock index. So we know that the shock index is heart rate divided by the systolic blood pressure. So it's normally varies from 0.5 to 7. So if patient is having a persistent elevation of shock index of more than 1, there is a significant high rate of mortality as well as they require massive transfusion. So according to ATLS, so patient who is having more than 0.9, they have a twice risk of massive transfusion. If more than 1.1, 4 times, and if more than 1.3, they have a 9 times risk of massive transfusion. So think about the shock index in any patient who is having a tachycardia with low blood pressure. Even you can apply for this patient, even though it is non-traumatic, but we thinking that this patient is having a hemorrhagic shock. So massive transfusion protocol, it's usually 1:1:1 packed red cells for FFP and the platelet, but it might slightly differ from institution to institution, but usual protocol is to 1:1:1. Few word about the hemoglobin and the hematocrit concentration. So acutely, there's no any drop in hemoglobin concentration or the increase in hematocrit concentration in patient who is acutely bleeding. So please don't rely on your hemoglobin level when you're trying to activate massive transfusion protocol, because it is usually given a false idea, as our patient who is at a 13.5 gram per deciliter. So we might think that falsely this patient is having a normal hemoglobin, and we might not tend to give the blood transfusion urgently. So please make sure. So I usually go with this bucket theory. So you have a 5 liter inside. So you take off 3 liters and you have it inside 2 liters. But if the solvent is same and your solvent is distributed equally, so your concentration should be normal. So don't rely your hemoglobin level or hematocrit level acutely to decide whether patient needs massive transfusion or not. So during resuscitation, you need to think about the hypothermia, acidosis, hypocalcemia, and hyperkalemia. So these are the lethal diamond, not the lethal triad. So you need to think about these as well. So if patient is on anticoagulant, especially patient is on warfarin or vitamin K antagonist, so you need to give vitamin K treatment, or ideally patient need the prothrombin complex concentrated or PCC. So if patient is on dabigatran, so is the reversal agent is idarucizumab. So you can give according to your local protocol or the NICE guideline. So if patient is in a rivaroxaban, apixaban, edoxaban, so in major hemorrhage, there is a limited data, but you can either give PCC or bariclax. So tranexamic acid. So everybody knows that the patient who is having acute bleeding, you need the tranexamic acid. It need to be given within 3 hours. But if they are more than given 3 hours, so there is a less evidence to support the giving tranexamic acid for the hemorrhagic patient. So you give 1 gram of tranexamic acid over 10 minutes, and the next is infusion over 8 hours. This is 1 gram. So everybody knows that the action of tranexamic acid. So we did the patient's CT aorta. If everybody can see that there's a significant dilatation of abdominal region. So in addition, actually, this patient had a abdominal aortic aneurysm, which is fistulating or rupture into the inferior vena cava. So there was no free fluid or pelvic hematoma, or there have been other extra-abdominal hematoma, because patient is fistulating and your aorta to the inferior vena cava. So Despite of supportive care, patient continued to deteriorate, and patient basically had a cardiac arrest, PE cardiac arrest, and so patient died. So, but the important thing which I want to elaborate is the shock index, when to activate massive transfusion protocol, and how to get the team dynamics and the multidisciplinary team approach. So, second patient, 65-year-old male who is known to have a hypertension on lisinopril, but does not have any previous heart disease. Basically, coming with the severe central chest pain 6 hours ago, associated with excessive sweating and dyspnea. So his vitals are heart rate of 124, blood pressure of low blood pressure is 85 to 55, tachycardic oxygen saturation on room air is 82, and it was improved to 92 on 15 liter of oxygen. So his initial assessment is diaphoretic, is cardiovascular, he is having a faint rapid heart rate, and he is having a weak peripheral pulses. And in addition, he is having a bilateral basal crepitation and cool clammy extremities with capillary refill of more than 4 seconds. So this is his ECG. It's showing obviously anterior STEMI. So if you can see this one, unfortunately I can't play this one. I don't know whether you can see multifocal confluent B lines. So, and his chest X-ray, you can see interstitial and the alveolar edema with enlarged heart or the cardiomegaly. So his ABG is having a metabolic acidosis, actually metabolic and the respiratory bioacidosis, and the lactate of 4.8. So his main investigation, which we did, came as troponin significantly elevated, BNP elevated, D-dimer elevated, and the lactate also significantly elevated. So what we are dealing in this patient is, so if you can see with the history, a 60-year-old patient coming with acute chest pain and is having a low blood pressure, tachycardia, and all the biomarkers are elevated, including troponin is significantly elevated. So he is having obviously cardiogenic shock, secondary to the acute coronary syndrome with acute decompensated heart failure. So how do you define cardiogenic shock? Is mnemonic is a suspect CS. So S is the symptoms, basically the low perfusion. You can see the patient is having a low mental status, cold clammy extremities, pulmonary congestion, and the raised JVP. U is urine output less than 30, and S is sustained hypotension, which might need which needs support, and the P is perfusion markers. The lactate is more than 2, and the metabolic acidosis, and the echo is echo evidence or the acute ischemia, and the C is congestion, and the T is triage early shock. So our patient had all these symptoms, so patient is definitely in cardiogenic shock. So cardiogenic shock, you do not necessarily have to have a hypotension, because if patient is having a signs of hypoperfusion with objective evidence of cardiac dysfunction, you can call it as a cardiogenic shock. You don't necessarily have a hypotension, but usually patient have a hypotension, persistent hypotension. So if patient is having a systolic blood pressure, persistent systolic blood pressure less than 90 with mean arterial pressure less than 65, so, and they usually have a cardiogenic shock. In addition, there's a primarily objective evidence of end-organ perfusion, which may be, as I said before, altered mental state, oliguria, cold clammy extremities, and elevated lactate level. So all these are evidence of end-organ perfusion, hypoperfusion. So in addition, you need to have a primary cardiac source of shock. So you might have a ECG evidence, you might have echocardiographic, basically echocardiographic evidence to say this patient is having a reduced cardiac function. Or else you might have a severe arrhythmia, patient might have acute valvular or mechanical pathology and myocarditis. So the fourth one is to classify is not the hypotension or the shock is not explained by the hypovolemia. So if you have these signs and symptoms, especially patient is having a hypoperfusion and objective evidence of cardiac dysfunction, you can classify it as a cardiogenic shock. So how do you categorize the cardiogenic shock? It's basically that there are pre-cardiogenic shock, and the refractory cardiogenic shock. But nowadays, we usually classify it as a phenotypes. There are 5 phenotypes. One is left ventricular, other one is right ventricular, other one is biventricular, mechanical, and the functional. So all these are now its phenotype basically depend on the bedside or the echocardiographic finding. So I will elaborate one by one quickly. So patient who is having a left ventricular dominant cardiogenic shock, they usually have a left ventricular or the diastolic dysfunction. So it might affect the low cardiac output and the pulmonary congestion. So bedside evidence or the focus evidence are the pulmonary edema and poor left ventricular contractility and the elevated filling pressure. So their clinical picture is cold and wet. So their main issue is the reduced left ventricular dysfunction. So main aim of treatment is to identify and fix the cause. So if patient is having an ACS, so immediate perfusion. If patient is having acute valvular pathology, so you need to correct it. So meantime, you can improve ventilation with non-invasive or invasive ventilation. So if patient is having a right ventricular dominant, so patient is having a right ventricular pump failure, so you have an inadequate left ventricular preload. So usually the causes are the right ventricular infarction, massive PE, acute pulmonary crisis, hypertension crisis. So these are the pathophysiology behind the right ventricular dominant cardiogenic shock. So bedside, you can see the dilated left ventricles, reduced left ventricular free wall motion, and septal shift, especially in patient who is having a PE. So clinical profile is cold and dry, or cold and congested sometimes. So their main management principles is to avoid excessive afterload, so and be cautious of giving diuretics. So you need to start early inotropes and avoid vasoconstrictors. So these are the main principles behind the management of right ventricular dominant cardiogenic shock. So if you classify patient is having a biventricular, so patient is having a significant left ventricular dysfunction with RV dilatation. So there is a combined right ventricular and left ventricular pathology. So the typical causes are the advanced cardiomyopathy, large anterior MI, pulmonary cardiomyopathy. So their main principal management are the hemodynamics. So initially you need to start norepinephrine to maintain MAP, and then you can add inotropes. So if patient is having a mixed cardiogenic at the distributive shock, so in addition to patient is having a pump failure, so you have a vasodilatation. So example, patient who is having a cardiogenic shock, having a SIRS or post-cardiac arrest syndrome. So these patients need both inotropic support, vasopressor support, might need the mechanical support as well. So if patient is having a mechanical or structural cardiogenic shock, especially patient who is having an acute mechanical obstruction, so the focus finding is the hyperdynamic or the non-severe depressed left ventricular function. So their main mechanism or the main management is drug. Usually drug will not fix, so they usually require either surgical or the structural intervention. So this is the summary. So of patient who is having a different kind of a phenotype of shock and how they manage. So our patient who is having a low blood pressure, tachycardia, so how are you going to manage? As I mentioned, this patient is definitely having a left ventricular dysfunction. So we need to improve patient's blood pressure. So we need to start with the inotropes. So later on, we can add on first you need to give a vasopressor. So, and then after that, you can give inotropes. So ideal vasopressor is norepinephrine. Okay, so you need to start vasopressor or the norepinephrine patient who is having a cardiogenic shock with mean arterial pressure less than 65. So after you start vasopressor, then you can add the inotropes. Especially, you can give either dobutamine or milrinone. So you know that the Dorami trial, so it has the both efficacy Dorami, which is for the cardiogenic shock. It has a both same efficacy and uh, the same efficacy for the dobutamine and the milrinone. So, so if patient is having a, as I mentioned before, if patient is having a low blood pressure, mean arterial pressure with hypotension, so please start first the norepinephrine, not the first line agent is the dobutamine. So now start norepinephrine and maintain the blood pressure. Then you can add the dobutamine. Okay. So, so this is the summary of vasoactive agent. So there are the advantage and disadvantage, but the first line vasoactive agent is the norepinephrine. So, so you need to consider the decongestion once the patient is stabilized. So don't give any furosemide or any loop diuretics while you have a patient who is having a significant low blood pressure. So if once patient is stabilized hemodynamically, so you can start decongestion. So you can give loop diuretics, and you can add on distal actin diuretics as well to enhance the natriuresis. So ideally, loop diuretics need to be given as not as a bolus, but as an infusion, small dose of infusion. So our patient, main underlying treatment, so as our patient who had acute coronary syndrome, so while you improve in patient hemodynamics, so you need to definitely activate the reperfusion pathway as well. Either you need to go for urgent PCI, ideally, or you can activate thrombolysis as well. So if patient is having an arrhythmia, so you can cardiovert or pace. So if patient is an valvular issue, so a patient might need urgent valvular repair. And the patient is having a myocarditis or other toxicology, so you need to treat the target. So there are mechanical devices. So I don't want to explain it in deep. So left ventricular dominant shock. So you need to have a left ventricular dominant. So you can see that there are a couple of devices for the left ventricular on your right and the right ventricular on your left. So you know that the Impella, IABP. So these are useful in patient who is having a left ventricular. And Impella is important for patient who is having a right ventricular Impella RP. So there are various kind of devices available for the patient who is needed the mechanical support. So it's depend on where the pathology is and where the structural defect is. So you can decide whether you need to go for a right ventricular or left ventricular or mixed type of mechanical support. So a few words about the ventilatory support. Since this patient is having a severe hypoxia, so you need to either give your patient support, oxygenation support. If it is going to fail, so you can start the initial ventilator, the mechanical ventilator or invasive ventilator. So ideally mode is AC mode. So your start FiO2 should be 100%. So you can step down to maintain equilibrium more than 92. So your tidal volume is 6 to 8 of ideal body weight, and your plateau pressure is less than 30 centimeter of water. And your respiratory rate should be kept in 10 to 20 beats per minute, and your PEEP should be monitored. Your PEEP is usually around 5-6. And depending on the patients, depending on your requirement, depending on the patient oxygen status, so you can adjust your PEEP level. Okay. So these are the ventilatory strategy, ventilatory support for the patient who is having a cardiogenic shock. So this patient, our patient who had the mechanical support, the inotropic support and the vasopressor support to within the first 24 hours, and then patient had the repeated echocardiogram after the thrombolysis. So patient had a improved left ventricular dysfunction. So patient ultimately saved. And so in cardiogenic shocks, especially for the second case, I want to elaborate this patient. So you need to identify whether this patient is in cardiogenic shock. So you need to identify which phenotype your patient is. So depending on the phenotype, you need to have stabilize the patient. While you stabilizing the patient, you need to treat the underlying cause, and you can escalate your patient early. Either you can mechanical ventilation and other reperfusion strategies, mechanical support, and the surgical support. So that is all about the shock management. So thank you very much. If you have any questions, so I'm happy to answer.